of imaging and abnormalities of pulmonary arteries. So to talk about pulmonary arteries, and we usually receive a lot of orders and requests to do pulmonary embolism studies to check for any pulmonary emboli, especially in emergency situations with chest pain, tachycardia, or tachypnea. We need to understand how the pulmonary arteries are distributed, the anatomy of the pulmonary artery, and then how to image them. And the last point, what are the different pathologies that we may face or find in the pulmonary arteries? So as an introduction, the main pulmonary artery may have diameter as great as 28 millimeter. We usually give it up to 3 centimeter or 30 millimeter as a normal pulmonary artery. And more than this, we start to say it is dilated or enlarged. The other important thing other than the size by itself, its relation or the size compared to the ascending aorta. So if the size of the pulmonary artery is equal or less than the ascending aorta is normal. If it is more than the ascending aorta and the size is still less than 3 centimeter, we call it dilated still if it's relatively more than the size of the aorta. The main left and right pulmonary arteries are intrapericardial, and the right pulmonary artery has a longer mediastinal course than the left, and it divides into two lobar branches at the root of the right lung. The left pulmonary artery courses over the left main bronchus and penetrates into the root of the left lung, where the artery divides into two lobar branches. We call the pulmonary artery we call the bronchus on the left side epiarterial. So the bronchus is, hip arterial or hypoarterial. So the artery courses above the bronchus on the left side. So right side on the other way around. So the artery courses below the right main bronchus. The segmental arteries are always seen near the accompanying branches of the bronchial tree, and the subsegmental arteries are easily recognized as dichotomous division of the corresponding segmental arteries. So dichotomous means two divisions. So each artery divided into two branches, branches divided into two branches, and so on. Pulmonary arteries, main lobar segmental and subsegmental with a diameter greater than 0.5 millimeter are referred to as elastic pulmonary arteries. So they are like systemic arteries, dilate and by the high pressure and then relax and open and close. So there is no muscle, it's just elastic tissue. They course downward along the bronchi to the subsegmental level, and their diameters are similar to those of the adjacent airways. The function of the elastic arteries is similar to that of the aorta to provide distensible reservoir for the ventricular ejection. The smaller arteries, less than 0.5 millimeters, they have muscles in their walls, the arterioles. And these small arterioles are the place where there is thickening of the small pulmonary artery and they can increase the pulmonary arterial pressure. We will see right now. Beyond the subsegmental bronchi, these vessels transition to muscular arteries, which accompany the peripheral airways downward to the level of the terminal bronchioles. As the smooth muscle layer progressively thins, these arteries become arterioles, which proceed along the respiratory bronchioles and alveolar ducts to eventually form a capillary network, and then this exchange oxygen with the air in the alveoli and so on. The primary pulmonary circulation comprises the entire venous return. So all the venous return from the body goes to the pulmonary artery circulation, and this is the main blood supply to the lung bilaterally. A second vascular network, the bronchial circulation, draws approximately 1% of the systemic cardiac output and transmits the blood at a pressure 6 times that is of the pulmonary circulation. So the bronchial circulation carries small amount of blood just to supply the wall of the airways and maintain the blood supply to these airways to the lung. But normally there is no oxygen exchange between the bronchial arterial blood and the airway. It is just to supply the airways themselves. But the main oxygen change happens at the arterioles and the capillary of the pulmonary circulation, pulmonary artery circulation, not the bronchial artery circulation. Normally, the bronchial circulation only supplies nutrient, as we mentioned, as not involved in the gas exchange. However, in certain pathological condition, when the pulmonary artery circulation start to stop working, occluded, congenitally absence, or whatever the situation, the bronchial start to increase in size and the anastomosis start to happen and you see more prominent bronchial arteries and now they can start to take some of the oxygenation process from the pulmonary circulation. We'll see some cases in the coming slides. How to image the pulmonary artery. Now we understand the anatomy, how the division happen, what is the main supply to the lung, and how to image these pulmonary arteries. So first thing and the common thing, chest X-ray, though it's not so specific, but it gives us an idea about the pulmonary circulation. Are they normal or they are prominent? So you see here that the left side of the heart is straight or concave sometime. This is the site where the pulmonary artery, main pulmonary artery is. So if this straightening or concavity become convexity, this means the main pulmonary artery is dilated. On the other side, on the right side, we see this branching artery going down, going up here. So this is the right side pulmonary artery, and the left side is under the heart here, and you see some branching here. So this is the normal shape. Normally, if you put your thumb or you put one of your finger on the X-ray, these arteries will not be larger than your finger. So this is a smaller artery and looks nice like this case. When you start to see them prominent, you see here the left border just below the aortic knob. The pulmonary artery, instead of being flat or concave, it becomes convex, bulging beyond this left side border. And you start to see also on the right side, this large pulmonary artery on the right side as well. This is hugely dilated. You see is we used to see something like this in cases with bilharziasis. Very advanced case, even we see something like elephant trunk. Like you see like an elephant head and the pulmonary artery is going out of it, or something like this and the pulmonary artery is coming out of it. So the very huge dilated pulmonary artery can be seen in the extreme cases of pulmonary arterial hypertension. In patients with pulmonary arterial hypertension or dilated main pulmonary artery, you see peripherally the lung, there is very scanty vessels. The vessels are not as much seen as here. So these decreased vessels or vascularity are due to small arteriolar thickening and constricting the blood to go. That's why there is peripheral dilatation and there is more distal scanty circulation. These patients, we see it with emphysema. The enlarged airspace compresses the small arteries, causing high pressure on the medial side and distal side. There is a scanty blood vessel in addition to the dilated airways, or it's not airways, the acini, causing emphysema. Conventional pulmonary angiography, this is invasive way. They put catheter in the pulmonary artery like this one, and they inject contrast and try to image the pulmonary artery to find out stenosis, to find out dissection. It is good diagnostic and therapeutic as well. So they can put a stent to bypass any stricture or any narrowing in the pulmonary artery. But as a diagnostic value, now the CTPE, CT pulmonary embolism protocol, like makes the use for this as a diagnostic value very, very few to look for it. Ultrasound usually good for the main or the root of the pulmonary artery, the root of the aorta, like we see here, the aortic root. Beside it, there is right atrium. You see RVOT here. You see the pulmonic valve. So this is the RA. This is the right ventricular outflow tract, and this is pulmonic valve and the main pulmonary artery, right main, left main, and that's it. You can see more than this. So it is like a tool that tells us if the pulmonary artery is dilated. So we start to look for why it is dilated. Is there a parenchymal reason? Is there a vascular reason? If there is something like a chronic pulmonary embolism, we start to do CT to figure it out. CT pulmonary artery or CTPE remains the gold standard for evaluating most vascular pathology due to its ability to clearly elucidate anatomical detail and is often the preferred imaging modality to get a detailed look to the complex pulmonary artery vascular anatomy and at least on initial assessment. So if the patient coming complaining of something and there is an initial assessment, there is a need to assess the pulmonary artery, CT is a good tool to prove or exclude any suspicion for the clinician for the later on step. What are the techniques? So we have to put few points in our mind when we do the PE technique, especially if you have technician who is just starting, or if you are troubleshooting for a study which is bad quality, you need to tell the technician to change something. So to change what, you have to know few steps for the technique to be able to manipulate them and change them to the better study. So first thing is the ROI, the region of interest. We usually put the ROIs, it's the region of interest on the main pulmonary artery and ask the patient to hold the breath in equal position or in expiration. Why in expiration? Because in expiration, you are creating a positive pressure inside the chest and you are preventing the blood to come from the IVC, and this IVC blood is non-contrast blood and will dilute your injected contrast in the upper limb vein. So either in neutral, which is good, because in inspiration, you are pushing more blood to come from the IVC. So this will dilute your contrast. So either neutral or expiration in some cases where there is high dynamic circulation, like young people, like pregnant ladies who want to exclude PE, we ask them to expiration and hold their breath after exhaling the air. Arms, as you know, arms should be above the head, okay? Because any arms besides the patient, the bones of the arm will make an artifact, will decrease the diagnostic value of the study. Contrast injection rate should be 5 cc's per second or more. So the higher the rate of contrast injection, the faster to deliver this contrast into the pulmonary artery and to scan the patient before contrast dilution. Okay, so contrast injection rate should be 5 cc's or higher to get a good contrast into the pulmonary artery on time. Contrast injection techniques, you have to know there are two ways of contrast injection technique. Either contrast bolus timing or bolus tracking. Bolus timing means we inject some of the contrast like 10 or 20 cc's and we ask the machine to monitor how long it will take for this contrast to go from the arm to the pulmonary artery. And depending on this time, we inject the rest of the contrast and the machine will start working after this previously evaluated time, like 5 seconds, 6 seconds, or whatever. The contrast bolus tracking, we put the ROI, as we mentioned, on the main pulmonary artery, and the machine keep checking every like few seconds or second to check how much contrast arrived to the main pulmonary artery. Once it is at the threshold, like 150 Hounsfield unit, 160 Hounsfield unit, whatever, depending on the machine, they start the scan. So there are two ways. Some patient, it is better to do contrast bolus tracking, especially if the patient not cooperative, or bolus timing if the patient is cooperative and we can inject 1 and 2 times and calculate in between and so on. So it depends on the patient situation. We choose which one to go for. ECG gating usually not needed unless there is a lot of motion here and you definitely need to exclude dissection or something in the main pulmonary artery. But otherwise, usually no ECG gated needed. Diagnostic exam contrast, we have to decide after this as a clinician or as a radiologist if this exam good to diagnose PE or not. So if the contrast density in the pulmonary artery is more than 230 Hounsfield unit, 220 Hounsfield unit, this is good study. Usually from 300 to 400 Hounsfield unit. But more than 230 is good. Why we are putting this number? Because if we are looking for chronic PE, low contrast density will let us miss the chronic PE. So we need a high level of contrast to be able to have contrast between either acute or chronic pulmonary embolism and the contrast within the vessel. So contrast density is important, and the contrast density should be higher than the aorta. It should have some blood, contrasted blood in the aorta more than pulmonary artery. And this is important. Why? Because if we don't have any contrast in the aorta, this is too early. Some of the arteries may not be opacified. We can't get the RV to LV ratio, for example. So we have to have some contrast in the left side or in the aorta, and compare this should be less than the contrast in pulmonary artery. By this way, we made sure that the aorta contrast reaches the aorta and all the small arteries were opacified, and we can compare the right and left ventricular sizes as well. Interpretation, each loop and segment should be examined. So you go up, examine right upper loop, finish it to the periphery, go down, examine middle loop, go down, examine the right lower loop, and then go up again to the left side. So loop by loop, segment by segment to make sure you didn't miss any small pulmonary embolism. You decide to repeat the exam only if you find a technical factor, something from this technical factor you need to improve or you can improve. But if something you can't improve, like patient with a broken arm beside him making artifacts, you can't raise it, don't repeat the exam. Patient is like disoriented and moving or breathing, you can't change this. So anything that in patient factor, you have to clarify this in the report so that the clinician doesn't keep sending the patient to repeat the exam or you ask to repeat the exam. This is not something out of the technician's hand and something out of your hand as well. So if technical things you can improve, you ask to repeat, but if you can't improve, don't repeat, don't expose the patient to more contrast or more radiation. MRI may become an attractive alternative for the CT for the diagnosis of PE with advantage of no ionizing radiation, possible reduced risk of complication from contrast administration, particularly if newer non-enhanced MR sequences are used. So there is MR sequence like white blood sequence. You can apply them and you can see the defect in the main pulmonary artery if there is a PE. This can save you contrast, this can save you radiation, but usually MRI takes time, takes arrangement, not as available as CT, but in case, if you want to use it, you can use it. Like this patient, this is post-contrast. You see filling defect here in the pulmonary artery. You see peripheral thickening of the chronic PE. You see filling defect here, and so on. So it can be used without contrast or with contrast to see the PE. Congenital anomaly in pediatric, also MRI is preferred because of the radiation exposure. PET imaging, PET FDG, a glucose analog shows increased tracer uptake in metabolically active process. It is often performed in the evaluation and staging of malignancy, but increased FDG avidity is also seen in inflammatory and infectious process. With respect to the pulmonary arteries, PET and PET-CT has a role to play in identifying pulmonary artery lesion, like malignant lesion, like you saw a lesion in the CTPE, doesn't look like thrombus, it is enhancing, it is occupying the pulmonary artery, you think about sarcoma. Okay, let's do PET FDG. If it is metabolically active, it is proved sarcoma rather than pulmonary embolism. The treatment will be different completely. Or patient with metastatic disease, and you want to see if the lesion, the metastatic lesion, is reaching to the heart, reach to the vessels, reach to the lung. You can know exactly how it is going. The other etiology in patient with vasculitis to show also the inflammation as metabolically active vessel wall, but you can see vasculitis is still with the MRI, with the CT, if there is enhancing vascular wall. But it's a way, at least. But I think it is very important if you are talking about a tumor. This patient, we suspected the pulmonary embolism, but the lesion was enhancing, not like a thrombus without enhancement. So we did a PET-CT. You see how the lesion is very metabolically active and take the FDG, and you see here the lesion, and you see another lesion in the lung as well. Okay, there may be another lesion in the spleen here as well. So it is helpful for tumor evaluation. Talking about pathology of the pulmonary artery, sorry to stop for this. There is a question saying which sequence. So the sequence we talked about in the MRI, either contrast, post contrast, because post contrast you will see the vessel enlightened with the contrast and you see filling defect, or T2 weighted or cine images. Cine images, which is a steady state free precision SSFP sequence, has white blood. So T2 actually will have a black blood, so T2 no. So it will be cine because it has white blood sequence, or the post-contrast imaging will have also high signal intensity in the blood vessel. So both of them can show the filling defects within the pulmonary artery. Going back to the pathology, so having this illustration, we can have a look on the pathology in the pulmonary vessels. So when we talk about pulmonary vessels, we are not talking only about the arteries, we are talking about veins, we are talking about vascular malformation, and we are talking about the small part is bronchial vasculature. So what we will focus on today is pulmonary artery abnormalities, congenital or acquired, and we will talk about also pulmonary arterial malformation. And in another time, if you would like, we can talk about the pulmonary veins. Starting from the congenital disorder of pulmonary artery, you may have pulmonary artery atresia or atrasia. And this pulmonary artery atresia, you will see the pulmonary artery completely either occluded or markedly diminutive. And you will see the patent ductus arteriosus here connecting the pulmonary artery with the aorta or aortic arch to compensate for this atretic pulmonary artery. We can also see this in the patient with Fallot tetralogy or tetralogy of Fallot with hypoplastic right ventricular outflow tract and the hypoplastic small pulmonary artery as well. If it is only by itself, pulmonary artery, they usually bypass it by putting conduit or a tube from outside the heart, outside the right ventricle, to connect it directly to the bifurcation of the pulmonary artery to bypass this atretic or very diminutive main pulmonary artery. This is a patient with congenital absence of one of the arteries. You see here absence of the left side. Usually the lung is small, and usually when the pulmonary artery is absent, as we see here, there is a lot of collateral vessels, mainly bronchial artery, become engorged, become increased in size and number to try to bypass this and keep the oxygen supply to the lung and oxygen exchange between the blood and the cyanide. The other anomaly, pulmonary artery sling, developmental failure of the left sixth aortic arch may lead to pulmonary artery sling. So instead of the normal division of the pulmonary artery take a course around the viscera in the lower neck and the mediastinum. Let's see here. So you see here the pulmonary artery, the left side, instead of just bifurcate here, it just take an abnormal course between the trachea and the esophagus. This is the case of it, chest CT. See the pulmonary artery taking a course between the compressed esophagus and trachea anteriorly. Idiopathic dilatation of the pulmonary trunk. So usually for any CT, we usually measure the main pulmonary artery to see how dilated it is. Sometimes idiopathically, in some patient, we find the pulmonary artery dilated without history of pulmonary embolism, without abnormalities in the lung, something idiopathic, something congenital. Diagnosis of exclusion. So we have to exclude first the presence of other parenchymal or vascular reasons that cause this dilatation. Then you can say it is idiopathic dilatation. Congenital dilated pulmonary trunk with normal pressure in absence of cardiopulmonary disease. Patients with this condition are by definition asymptomatic. although close follow-up is recommended to make sure there is nothing else going on. Okay, so you see pulmonary artery here is 3.2 centimeter. Normally, as we mentioned, up to 3 centimeter, like with putting 2 millimeter more than the normal diameter. Talking about acquired disorder, pulmonary artery filling defect, this is number one disorder. So the first thing in pulmonary artery and the most common thing to find a filling defect in the pulmonary artery after giving contrast. So this defect could be pulmonary thromboembolism, non-thrombotic pulmonary embolism, or pulmonary artery tumor, either primary or secondary, which could be extension from a nearby organ like lung, or it could be secondary metastasizing from another place and lodged in one of the pulmonary arteries. Pulmonary artery filling defect, talking about the pulmonary thromboembolism, which is the most common reason why we are doing CT pulmonary artery and most common reason to find a filling defect within a pulmonary artery. PE is a serious condition responsible for significant morbidity and mortality. That's why keep an eye. I even review the vessels on a CT chest with contrast, not for PE. For any chest CT with contrast, I check for PE. I can tell you also that cases chest CT without contrast, you can see some shadows in the pulmonary artery if there is a PE, like hyperdensity in some of the pulmonary artery, abnormal shape like dilatation, even without contrast. Once your eye gets used to see the pulmonary artery, you can pick abnormality even without contrast. And when I ask for contrast, you find abnormality, dilatation, defect, or something like this. So keep your eye sensitive to any pulmonary artery abnormality in even the regular chest CT. PE is the third leading cause of death for cardiovascular condition after coronary artery disease and cerebrovascular accidents. Although imaging has a key role in the diagnosis of PE, clinical assessment of the patient is the first and most crucial step, because if this not happen, you will find all the ER doctors sending cases with chest pain, with tachycardia, go do chest CT for PE, chest CT for PE. So you will find a big pile of cases, but 95% of them are normal cases and they can be excluded easily by clinical evaluation, as we will see. When PE is suspected, clinical probability of PE should be determined before proceeding with testing. Validated scoring system include, but is not inclusive of modified Wells scoring, revised Geneva scoring system, and pulmonary embolism rule out criteria. Recent guidelines have suggested that, number one, patients who have a low pre-test probability of PE, as we will see later, and who meet all pulmonary embolism rule out criteria. So they rule out the criteria for PE clinically, and the low pre-test probability by these tests we mentioned, D-dimer measurement or imaging should not be obtained. So if clinically this patient has very low probability, nothing else should be done regarding the PE. Patient who have an intermediate pretest probability of PE, or patient with low pretest probability of PE who don't meet all pulmonary embolism rule out criteria, start with the D-dimer measurement, which should be obtained for initial diagnosis, with imaging only considered if the D-dimer is positive. So the easiest thing to ask any referred case for PE, do you have a D-dimer or not? At least. So even if they didn't test the patient or examine the patient, D-dimer, if it is negative, don't refer the patient. They have to look for other causes of chest pain or tachycardia or tachypnea. Patient with high pretest probability for PE, CTPA should be obtained, and D-dimer testing should not be used when the clinical probability of PE is high, as the test has low negative predictive value in such cases. If the patient already have high probability, you don't ask even for the D-dimer before the scan. So it is very important to correlate the probability and the D-dimer before proceeding with the CT. Is this patient low or intermediate or high probability? If intermediate, do you have D-dimer or not? If low, let the patient go on in need. If high probability, go for the CT directly, even without doing D-dimer. Don't waste more time. This is an example of revised Geneva scoring system. So they depend on the age, and give it +1, and different other criteria from the patient's history, and give it +3, +2, +4, +5, and so on. And then they sum, see how many of them are positive, and sum the number. And if the score is less than 3, this is low probability. Prevalence of PE is 8%, very low. If the patient score is more than 11, it is high probability, and the prevalence is 74% for the PE. In between these two numbers, 3 to 11, is intermediate. They have to depend on the D dimer. Will chest radiograph help us? There are some signs historically were used before the CT. We can still have a look on them or keep them in mind in case there is anything coming. Radiographic abnormalities in patients with acute PE, although very common, are non-specific. A chest radiograph is obtained to exclude other diagnoses that might mimic PE, such as pneumonia, pneumothorax, rib fracture, and provide information to help interpret the centigram or VQ mismatch. Westmark sign, you see some oligemic change here in the lung. If you compare this, you see some vessels, but this part of the lung is oligemic. Vessels are not giving much blood supply, so there is probably proximal obstruction. Another sign which is called Hampton-Hum sign. So Hampton-Hum sign means there is consolidation peripherally, plural base, which is infarction. You will see it in the CT chest. Pala sign, dilated right main pulmonary artery, and Westmark sign, again, there is oligemic change. So when you see the right pulmonary artery dilated, okay, and you see this Hampton-Hum sign and the oligemic changes, this means there is central pulmonary embolus. The main pulmonary artery is slightly convex here. This is something else to keep in mind for pulmonary arterial hypertension. As we mentioned, there is dilated pulmonary artery, okay, and there is dilated right main pulmonary artery. This dilated pulmonary artery, they give it Fleischner sign, and this sign is called Pala sign. Yeah, it's good to keep them in mind in case you are reading chest X-ray and you see them. It will alarm you to do chest CT to make sure there is nothing acute or something else underlying it. VQ scintigraphy or ventilation perfusion scintigraphy. Acute pulmonary embolus on VQ scintigraphy perfusion scan demonstrate bilateral moderate and large perfusion. Ventilation scan demonstrate normal ventilation. So this is the ventilation scan using xenon 133. You see that both lungs are receiving equally the xenon which is inhaled, so it goes to the airways. So if there is an airway disease or there is a parenchymal disease, you will find a defect in the ventilation that matches the perfusion. But if you find a good ventilation, but the perfusion using technetium 99 is patchy like this, you see this patch, this patch, this patch peripherally here, this patch here, here. So all these patches means there is a perfusion defect. This is called ventilation perfusion mismatch. There is bad perfusion, but there is very good ventilation. Why we are saying this? Because we expect that the areas with bad ventilation due to parenchymal disease, there is vasoconstriction in this area and there is redistribution of the blood. So in the areas with parenchymal disease, you will find ventilation and the perfusion problems in the affected part of the lung. CTPE, again, we mentioned that CT is the gold standard for this. Acute pulmonary embolism, what is the CT finding? You will find a filling defect within the center of the vessel, something like this. We call it donut sign, Bolomen sign. You will find saddle-shaped thrombus like this because the thrombus coming or the embolus coming from the lower limb, DVT, it will stuck at the bifurcation because it is small, keep going, going, going in the vessel till it bifurcates and then it's stuck to the smallest blood vessel. So you'll find the rounded inside the lumen filling defect. Right heart strain, you find right heart strain only if there is extensive load of the emboli, and this extensive load of the emboli obstruct the peripheral circulation, and this obstruction goes acute, increase in the pulmonary artery blood pressure, and you see here, right side of the heart is dilated more than the left side in the heart, so we call it RV to LV ratio more than 1. And the septum, instead of being convex to the right side, it is either flattened or convex to the left side, or bouncing, moving, because of the pressure difference in the right and left. It is important in your impression to mention you see pulmonary embolism or not, acute or chronic, because the treatment will be different from acute to chronic. You will say which part of the vessel is affected, central or peripheral, because it also makes difference in the management. And you mentioned if there is associated right heart strain or not. And the last thing to mention, if there is associated pulmonary parenchymal changes, meaning there is infarction going on or evolving infarction or not. So you mentioned acute or chronic, distribution, the load of this emboli causing right heart strain or not, and then last thing mention the parenchymal lung disease. If there is right heart strain, we call it submassive pulmonary embolism, because massive pulmonary embolism, you have to add the clinical part to it to call it massive. So there is clinical instability and the submassive pulmonary embolism. That's why the patient has massive pulmonary embolism. So don't say massive in your report, just submassive is the highest or the strongest presentation of the pulmonary embolism. Chronic PE signs, you will find the primary signs and secondary signs. Primary signs, complete occlusion of a vessel, complete obstruction, lines of decreased opacity can cause vascular webs, as you see here, vascular webs, scalloped shape or scalloped look vascular wall, okay, thickening of the vessel wall and the thrombus is contracted, abrupt narrowing, so you find the vessel going and then suddenly the vessel become very small and you don't even see contrast going distal to the vessel. Contrast flowing through thickened pulmonary arteries, as you mentioned. You may find also calcification. So this thrombus over time calcifies and you will find pulmonary artery calcification. The secondary sign is abnormal enlargement of the bronchial and systemic collaterals. You will find the collateral circulation trying to fill this area with obstructed artery, so they dilate. And you will find mosaic attenuation, because we mentioned that the parenchyma of the lung, to give its chastity shape, usually you have air and vessels. If there is no vessels going to it, it will have air only, so it will be loosened, more loosened. And the area beside it will have more blood, so it will appear white, giving you what is called the mosaic attenuation. Enlargement of the main pulmonary artery, peripheral pleural-based wedge-shaped dynasties due to old infarction. So you will see some indirect sign in the lung, some indirect sign in the vessel, but direct sign you may see it or you may not see it. There is a question here saying, how common is the airspace disease in the context of PE to be infarction other than other causes of airspace disease, including infection? So to have infarction with a PE is not so common unless you have complete occlusion of the pulmonary artery, because as you mentioned, there is other blood supply coming from the bronchial artery. So if the pulmonary artery is not completely occluded, the bronchial artery still can help. But to have infarction, you have to completely occlude the pulmonary. So it is not common. It is not common to see infarction with the cases of the pulmonary embolism. Number two, infarction usually peripheral and wedge shape. But if there is infection, and it can happen, can concomitantly happen, like patient with COVID. COVID, they have infection and they have PE. You will find the infection distribution is more in the parenchyma, more lower lobar, more patchy, not wedge shape, and to the peripheral. Okay, so infection is all over the place, but and it could be on the other side as well, not only restricted to the area of pulmonary embolism. So you can differentiate them. You can differentiate also through the clinical signs, patient with fever, infection manifestation, or patient coming with chest pain, tachypneic. If you are talking about VQ mismatch, it may be difficult in this situation because those patients with infarct may have also some ventilation problems. So you will go for CT rather than the VQ mismatch. Chronic pulmonary embolism also can be a diagnostic dilemma if you have other situation. We mentioned the difference between the chronic and the acute. The other thing, there is chronic pulmonary embolus and pulmonary artery sarcoma, and we talked about this earlier. Sarcoma, there is a defect, filling defect, but there is enhancement. And if you suspect there is enhancing lesion, not PE, you go for FDG or PET-CT, you will find some enhancement, not enhancement, FDG uptake and avidity of this lesion. You can also do some delayed enhancement of this case, and you see that this lesion is retaining more contrast. You may find also here the sarcoma extending beyond the vessel wall, but the embolus will be inside the vessel. In the follow-up, also sarcoma will increase in size, but the PE within 1 week or 10 days, it will become to shrink and decrease in size. Vasculitis is another thing because with vasculitis, the vessels start to close and there is collateral circulation. But again, in those patients, you will find the involvement of other arteries other than the pulmonary artery. You will find the mural thickening and you will find the most of the disease is in the wall, not inside the lumen. And if you do an PET-CT, you will find enhancement or FDG uptake in the wall rather than in the lumen. The last thing that can be differentiated from chronic PE is proximal interruption of pulmonary artery. Usually, you will find this in patient like congenital anomaly, as you mentioned early, patient, usually child, single site of occlusion, not on different place like PE. It is smooth tapering of pulmonary artery which ends at the hilum without endoluminary change, nothing inside the lumen. It is just the artery disappear or close abruptly without any other manifestation. So we have to keep this differential diagnosis in our mind when we compare it to the chronic PE. MRI, as we mentioned, can play a role for PE, and this is a CT, you see the defect here, and you can see an MRI here with, you can use either post-contrast image or you can use cine image, and you can see here that with cine image, it has T1 and T2 characteristics. You see the CSF is bright here. So the blood also in the white blood sequence, the cine image is bright. So you can see filling defect in it. But usually we don't do a MRI in acute settings unless the patient is contraindicated for CT, definitely can't withstand CT, contrast sensitivity, pregnancy. If the MRI is available, we can substitute the CT with the MRI. Yes, it is better to think in addition to the pulmonary embolism and infarction, we have to think on other causes as well, especially if the clinical situation permits. Non-thrombotic pulmonary embolism is an uncommon condition, and by non-thrombotic means anything in the blood vessel, in the pulmonary vessels, not thrombus, not related to the thrombus. It is usually involve particles that are so small that they are not depicted as an intra-arterial filling defects. Possible etiology could be fat, bubble of air, nitrogen, tumors, foreign bodies such as talc or cement. It is very common, especially when we are like first or second year of residency, to have a question. I want to check if there is an air or fat embolism. Air embolism may be very small, you can see it. And the fat embolism, actually, which is sometimes a wrong concept, you think about fat embolism as you will see a filling defect in the pulmonary artery, which is wrong, especially in patient with femur fracture and coming with tachypnea and tachycardia, and they ask you to check for fat embolism. Fat embolism present not with a filling defect, but present with patchy ground glass opacities in both lungs, something like this. Okay, so when you see a patient with sudden oxygen desaturation 2 days after internal fixation of tibial fracture, femur fracture, and patient with normal and come with a CT feature of patchy ground glass opacities, you start to think about fat embolism. This patient has a fracture tube or line, and this metastatic fracture line goes to the lung. And usually, if you check the X-rays before, you will see there was a line, and a small part of it get broken. Pulmonary artery tumor, we just mentioned how to differentiate with the chronic pulmonary embolism. You see, the tumor is enhancing. The filling defect is not hypodense. It is enhancing, not as the artery, but at least it is taking contrast. In this situation, PET-CT demonstrates this FDG-avid tumor. Next entity, we talked about filling defect, and we talked about thromboembolic, we talked about tumor, we talked about non-thrombotic. Second entity after filling defect is pulmonary artery vasculitis, large vessel vasculitis such as Takayasu arthritis, giant cell arthritis, Behçet disease, predominantly affects the aorta and its largest branches. However, pulmonary artery also can be involved. Takayasu arthritis is an idiopathic vascular disorder characterized by granulomatous inflammation of the arterial wall with marked intimal proliferation and fibrosis of the media and adventitia, usually less than 40-year-old. Pulmonary artery involvement is 50 to 80%. Common finding is stenosis or occlusion of segmental subsegmental artery. Less common is the lobar or main artery occlusion in the Takayasu. And when you do a CT, you will find there is a thickening in the ascending aortic wall, maybe even intimal disruption, and there is some pseudoaneurysm formation here in this patient because of the weak inflamed intima and the vascular wall. When you go to the pulmonary artery, instead of seeing like normal pulmonary artery, you will find diminished lumen and thickened wall around it. Again, if you do an FDG, there may be an FDG uptake around the artery, not something inside the arterial lumen. Giant cell arthritis is most common vasculitis involving large and medium-sized artery. It almost exclusively affects patients over 50 years and rarely affects the central pulmonary artery. Pulmonary artery involvement is much less common with giant cell arthritis compared to Takayasu. And CT MRI findings are like that of Takayasu, nothing changed because it's again inflammation in the wall of the arteries. Behçet disease or Behçet disease is a chronic multisystem vasculitis which can involve large, medium, or small vessel of both arterial and venous circulation. The problem in this Behçet, or one of the diagnostic, you will find pseudoaneurysm or aneurysmal dilatation in many arteries which are not close to each other. So you can say it is post-traumatic, you can say it's iatrogenic. No, and there is some vessel thickening as well, in addition to the history for sure. Usually manifests in the second or third decade, usually young patient. Reported prevalence of thoracic involvement is up to 8%. Behçet disease is most common cause of pulmonary artery aneurysm due to inflammation of the vasa vasorum of the tunica media with destruction of the elastic fiber resulting in dilatation of the vessel lumen. Multiple aneurysm, bilateral, located in the lower lobe of pulmonary artery or main pulmonary arteries. They are frequently or partially or totally thrombosed, so you will find the dilated part and the thrombus, mural thrombus along its periphery. Thickening of the wall of the aorta or spirovena cava, obstruction, thromboembolism, pulmonary infarction as a consequence of this vascular inflammation. You see here the spirovena cava is thrombosed. You will see multiple thickened nodule. If you open it a little bit, you see it along the artery. So this means the artery is thrombosed, inflamed, and there is ground glass opacity around it. Okay, multiple pulmonary artery aneurysm, and there is thrombosis along its wall. So this is very characteristic with the patient's age to start think about Behçet disease. Pulmonary artery aneurysm and pseudoaneurysm, whether congenital or acquired, are rare, so not commonly seen, but important to recognize because of the associated mortality. Aneurysm is focal dilatation, involves the three layers of the pulmonary artery. Pseudoaneurysm, you will find a break in the intima or break of the three layers, and the blood is surrounded by the surrounding tissue only. Etiology could be congenital anomaly, especially in patients with PDA, infection like mycotic aneurysm, we will see a case together, neoplasm, vascular abnormalities like vasculitis, as we mentioned, about Behçet disease, and trauma, iatrogenic, especially following pulmonary artery catheterization, they can hit the wall and cause intimal tear. You see this patient with pulmonary artery pseudoaneurysm in a pulmonary or large lung mass, okay, due to weakening of the pulmonary artery, so it dilates and cause an aneurysm. This patient has an esophageal air fluid level here. Okay, so this make us think about distal obstruction. And in addition to this the obstruction laterally, we see here there is large mass with central cavitation in the right lower lobe. So we start to think about, is this either mass or infection with cavitation, or there is aspiration. You see here the air fluid level as well here in the esophagus. And with the CT, you start to see this mass with aneurysm here in this, and this is dilated esophagus as well. So this is a patient with esophageal tumor, aspiration causing infection or pneumonitis, and the mycotic aneurysm within this focus. They did the angiogram and they coiled the pulmonary artery pseudoaneurysm or aneurysm. Iatrogenic, following, as you see here, the Swan-Ganz catheter or pulmonary artery catheter. You see here area of patchy airspace opacities, and when they do pulmonary angio, they found a small aneurysm because the catheter injured the small vessel and they coiled it later on. Pulmonary artery vascular malformation are abnormal direct communication between the artery and vein bypassing the capillary bed. The resulting anatomic right to left shunt allows systemic blood to bypass gas exchange and pulmonary capillary bed processing. Clinical manifestations include asymptomatic dyspnea, hemorrhage, paradoxical emboli, cerebral abscess, or myocardial infarction. All this because of the emboli crossing from the right side to the left side systemic circulation. Pulmonary arteriovenous malformation hemorrhage can be fatal, okay, although it is relatively rare. As many as 90% of those cases will prove to have hereditary hemorrhagic telangiectasia, and conversely, they are present in up to 50% of patients with hereditary hemorrhagic So patient with hereditary hemorrhagic telangiectasia will have up to 50% of them this PAVM, and PAVM is commonly found, like most of the patient, we are seeing them in the hereditary hemorrhagic telangiectasia. When I say this, I mean if you see one, you will find more than one in the lung. So if the patient coming with this history, look for the pulmonary arteriovenous malformation, you will find many of them. They are often multiple, bilateral, preferentially located in the lung basis, which is contrary to the sporadic cases. This PAVM consists of three differential anatomic components, one or more feeding vessel, aneurysmal part, which may be sac or serpiginous, and then draining vein. So the most important thing when you suspect it, you have to keep tracking till you find the feeding vessel, artery, and the draining vein. Once you see this component, the nodular shape and one artery in, one vein out, this is the AVM. Simple one, which accounts for approximately 80%, is characterized by one or more afferent feeding vessel originating from single segment pulmonary artery complex. You will find multiple feeding arteries. So complex one is more difficult to treat or to call because of the multiplicity of the vessel. So in the X-ray, you may see some nodular thing. You may be see serpiginous vessel here, but the CT can show you the main secular appearance, and you can see the feeding vessel and draining vein in the pulmonary arterial venous malformation. Last thing, pulmonary arterial hypertension, which is the situation when we see pulmonary artery dilated and pulmonary arterial pressure more than 25 millimeter mercury. Now they are saying more than 20 millimeter mercury, because normally is less than 20 millimeter mercury. There are many causes for pulmonary arterial hypertension. Could be primary, patient like having this abnormality with thickened arterioles and increasing the central blood pressure, or could be secondary to cardiac problem, or could be secondary to parenchymal problem. Cardiac problem like left heart failure can increase the pressure on the right side over time. Lung parenchymal problem like hypoxemia, like emphysema over time compress the peripheral arteries causing pulmonary hypertension. Vascular problem also could be thromboembolism, chronic one. Um, Pulmonary hypertension with unclear multifactorial mechanism, something else can happen. So when you see pulmonary hypertension, you start to see look on the left side of the heart, see if there is left heart failure or not. Parenchymal causes like fibrosis or emphysema, and then look on the vascular causes like signs of chronic pulmonary thromboembolism as well. Okay, as we mentioned, the pulmonary artery with diameter 29 millimeter or 30 millimeter or more is positive, has a very high predictive value, and the ratio of the main pulmonary artery diameter to the ascending aorta is also important. So those are my references, and thank you.
شكرا جزيلا دكتور مينا. أنا بس عايز أسأل هل في precautions معينة في حالات السي تي pulmonary angiography، بحيث إن إحنا بنشوف تكنيكس كتيرة ما بتبقاش يعني technically يعني diagnostic، يعني
Yes.
هل في حاجات معينة نقدر نقولها للتكنيشنز إن هم كتايمنج او غيره ان احنا تو obtain proper technique؟
هو اهم حاجه مفيش بريكوشن معينه، ولكن هي كلها education and experience. يعني I remember when I started working انا جمعت التكنيشنز كلهم بتوع السي تي، واديت لهم زي محاضره كده هوت about البلمونري امبوليزم واباوت السي تي pulmonary بروتوكول، وليه اتس امبورتنت، وليه لازم يرفع ايدين البيشنت ما يخليهاش جنبه، لان سام تكنيشن say it's fine I inject the contrast whatever، يعني مش هوجع دماغي. لكن tell them that patient's hand arms beside the patient دي مشكله، هتعمل لي ارتفاكت، مش هتبقى diagnostic وهتعيد لي للسايد تاني. الانجكشن ريت مهم، لازم تخلي الانجكشن ريت بتاعك عالي 5 او اعلى. خلي بالك من نفس العيان وجيف هيم تريننج بيفور يو ستارت. ما تقولش للبيشنت اسمع الماشين بتقول ايه خد نفس واكتمه وبس، لا، تعمل براكتس مع البيشنت وتقول للبيشنت لما تسمع الماشين وقف نفسك، ما تاخدش نفس ولا تطلع نفس، او لو مش قادر تطلع نفس واكتمه، يعني يا ده يا ده. لان ساعات مش بيكلموا البيشنت، فالبيشنت يسمع الانستراكشن واخد نفس خلاص دخل نون كونتراست بلاد مع الكونتراست بلاد، الاستادي خلاص باظت منه. فمهم قوي الكلام مع البيشنت، بنسميها بيشنت كوتشنج، نعمل كوتشنج للبيشنت. طب اعمل كده، طب اعمله كده قدامي مره اتنين، كمان كده تمام كده ممتاز. نمره اتنين ايدين البيشنت فوق راسه. نمره تلاته الانجكشن ريت والانجكشن تايمينج فيري امبورتنت. بوت الار او اي على المين بالمونري ارتري، مش على الفنتريكل ولا على الايورتا، بوت على المين بالمونري ارتري. فهي كلها دكتور هشام هي كوتشنج وبراكتس وتكوركت زم. يعني مثلا ما نلاقيش استادي كده مش حلوه نقول خلاص بقى عيدها وخلاص، ما نكلمهمش، لا ما نقولش عيدها وخلاص، نكلمه ونقول له انت عملت ايه، طب ايه المشكله اللي انت قابلتها، وتعلمه. المره اللي بعديها تلاقيها احسن، المره اللي بعديها تلاقيها احسن، وهكذا لغايه لما يتعلم. فهي كلها جود كوميونيكيشن with the technician، وناخد وقت شويه في ان احنا نعلمهم. لو هم عندهم اكسبيرينس ويل اند جود، عندهم شويه ديفكت نصلح لهم الديفكت وخلاص. فهي كلها حكايه ايه، تظبيط التكنيشن. الحاجه التانيه اللي ساعات تبقى اجينست اس هي الماشين. يعني لو احنا مثلا عندنا اولد ماشين شويه، التكنيشن المفروض لو قديم بيبقى عارف الماشين بتاعته عندها ديلي تايم قد ايه، فبيروح مظبط نفسه. نيو ماشينز ار فيري فاست، ممكن تجيب لي ايرلي ستادي اظبط التايمنج بتاعي وهكذا. فهي كلها تكنيشن كوميونيكيشن وليرنينج بروسيس لغايه لما يتظبط التايمنج مع البيشنت مع الاديوكيشن.
تمام. طيب هل في ابلكيشنز دلوقتي للدول انرجي سي تي في حالات
طبعا.
البلمونري؟ اه.
طبعا الديوال انرجي
مم.
سي تي ناو في اماكن معينه بيريبليس كمان الفي كيو مس ماتش، لان هو الديوال انرجي سي تي بيدينا مابس بنسميها ايوداين مابس وكالرد مابس. بنقدر نشوف الحالات اللي وصل لها الايوداين انجكتد ايوداين وفيها جود فنتليشن، يبقى دي في في كيو ماتشنج، سو دي ما فيش اوبستراكشن. لكن لو في بالمونري امبوليزم اوبستراكتنج ارتري ومش عامل برفيوجن، يبقى في عندي في كيو مس ماتش. بقدر منه اطلع الحالات اللي فيها امبولاي بس انا مش شايفها بعينيا المجرده، لان هي very small و very peripheral. The only drawback for the dual energy، ما ينفعش اديبند on it only. يعني ما ينفعش اول حاجه افتحها هو الديوال انرجي، لازم اقرا الاستادي كلها as usual. بعد كده open the dual energy، اشوف المابس واشوف these maps will help me to add value or these maps are not adding value. لان sometimes if the pulmonary embolus not obstructing you will find good perfusion. Sometimes there is a small pulmonary embolism and you don't see it from the map because the colors are not well registered over each other. Sometimes there is some motion, the maps are not good. So I'm not depending on the map only. I read the study and add value with this map to help me for the small emboli which I can see.
طيب السؤال الأخير دكتور مينا،
اتفضل.
العيانين اللي هم كونترا انديكيتد إننا نحقنهم في حالات البلمونري امبوليزم، هل النون كونتراست سي تي ليه أي فاليو في الاسسمنت بتاع البلمونري امبوليزم؟ وهل لو احنا عملنا ام ار هل ده يعني هيدي ريزلتس؟
النون كونتراست سي تي هيبقى مور اور ليس فيري كلوز تو اكني بشوف اكس راي تشيست. هشوف الاندايركت ساينز، هشوف dilated main pulmonary artery فور اكزامبل، هشوف انفاركشن لو في peripheral infarction. Maybe if I am lucky to see hyperdense filling defect or hyperdensity along the vessels and say it could be pulmonary embolus, but again it will be suspicion، مش هقدر ابني عليها treatment. يعني for PE محتاج ادي انتي كواجوليشن، فانا I can't build my treatment on suspicion. MRI will be better especially if I do the cine images, so I open the field of view to get more vessels in the field of view. I can see the large vessel to the lobar or segmental even with a filling defect to call for PE. If I can give contrast, I can do also part of the study with contrast in the MRI. So MRI will be better than non-contrast CT if this is the question. There is a question here to saying regarding cause of mosaic attenuation, how to differentiate between chronic PE and small airway disease? Yeah, very good question. For the PE study, to differentiate between, so let's understand what happens. So small airway disease will do what? Will do air entrapment, okay? But the vessels will be normal. The vascular disease because of the chronic PE will cause vascular abnormalities. The vessel is abnormal, but the air acyani is normal. So in the study, like CT with contrast, the only differentiation will be the size of the vessel. So you check the area with lucency. If you have vessel size like the size of the vessel in the high density area, the vessel size is equal. So this is likely small airway disease and usually acute, because chronic small airway disease will give us the same problem. Small airway disease, chronic, will have vascular contraction and the redistribution again. The best way to differentiate is using high resolution CT. So we do regular inspiration and we do expiratory phase. In the expiratory phase, you will go to the lucent area. If this lucent area in the inspiration become more dense with expiration, this means there is no small airway disease. This is mainly vascular because the air which goes in goes out again. If there is a small airway disease, it will make like a one valve procedure. So the air goes in, stay in. So during expiration, you will not have much difference in the density of this lucent area. Make sense? دكتور أحمد السايج. Make sense؟ ولا مين اللي كان سأل السؤال ده؟ سوري. لا دكتور ار، ما اعرفش مين دكتور ار. So I hope it makes sense. So you can use the vessel size if you don't have high resolution. If you have high resolution CT, you can use the inspiration and the expiration. دكتور أحمد بيسأل is there any clue in imaging for suspect amniotic fluid embolism? No, amniotic fluid embolism is just a fluid. Um, I haven't seen any case amniotic fluid embolism, and it doesn't have something specific. Probably it will not have a filling defect, but it may be have some areas of increased ground glass opacity like the fat embolism because of the inflammation and the edema it produces. But I haven't seen a case of amniotic fluid embolism, and I haven't read something about it. Where can I find it? شكرا. العفو يا فندم. الأسئلة بقى لحضرتك دكتور هشام. Is there more session today or where can I find the recording? أشكركم على الحضور مرة تانية، وأنا تحت أمركم في أي وقت. لو عندكم أي أسئلة ليا في أي وقت ممكن تبعتوها لي. أحط لكم الإيميل بتاعي تحت هنا اهوت، لو في حد عنده أي سؤال ممكن يبعته لي. أوكي، يلا شكرا يا فندم. باي باي.
شكرا جزيلا دكتور مينا.
العفو يا دكتور هشام، تؤمر في أي وقت.
شكرا جزيلا، وإن شاء الله يعني في انتظار مشاركة حضرتك إن شاء الله في مرات قادمة إن شاء الله.
أكيد يا فندم، تؤمر في أي وقت. سلام يا
شكرا
فندم.
شكرا جزيلا، شكرا
مع
جزيلا.
السلامة.
نلتقي في الجمعة الجاية إن شاء الله يا شباب. السلام عليكم.